So once again, a very warm welcome to our teaching program today in the Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a case discussion on a case of hematuria. So we have first year resident, Dr. Sahib Singh Yadav, who will present the case. And this will be discussed with the third year resident, Dr. Sanjay Saini. And today's moderator is one of our faculty, is Dr. Govind Sharma. And we have two special invitees with us. So I will just introduce them. So we have Dr. M.M. Bansal. He is a very senior urologist, one of the earliest SMS alumni who passed out from our department. And he is at present a senior consultant urologist at Fortis Hospital, Jaipur. So welcome, sir, Dr. M.M. Bansal, and thank you for having spared your valuable time. And the next invitee with us today is Dr. Aditya Pradhan. He is presently Director of Urology and Kidney Hospital Transplantation Center, BLK Super Speciality Hospital, New Delhi. And he has interest in uro-oncology, robotics, and renal transplantations. And he has multiple publications. So thank you, Dr. Aditya Pradhan, for joining us. And thank you very much. So we would start, and I would now hand over to Dr. Govind Sharma to invite the presenter. Dr. Govind Sharma, please.
All faculty members and special invitees, Dr. M.M. Bansal sir, our very own.
The forcible conversion of the sick girls and the forcible marriage to a man twice
and I would like to.
Govind, you are not audible. You are not audible, please. You are just unmute yourself. Unmute yourself.
गोविंद माइक थोड़ा दूर है गोविंद आपसे थोड़ा माइक पास में करो
Hello.
Yes,
your voice is very anyway I would request Dr. Sahib Singh to start sharing his presentation, and then Govind Sharma would join us. Yes, Sahib Singh, share your presentation. Yes.
Thank you so much. Good evening, my respected teachers, seniors, and my dear colleagues. I'm here to present a case of 64-year-old male presented to urology OPD with chief complaints of hematuria since 3 months, increased frequency of the maturation since 3 months. History of the present illness: the patient was apparently all right 3 months back when he had complained of the hematuria that was total, gross, and painless, associated with the presence of the amorphous clot. And the frequency of the hematuria was 5 episodes in 3 months, but 10 to 12 episodes in last 6 days. Second, the increased frequency of the maturation, that was 8 to 10 times in a day and 2 to 3 times in a night. Moving on to the negative history, the patient has no history of the burning maturation and fever, no history of the flank pain, lower abdominal pain, no history of the urgency and urge incontinence, no history of the poor urinary stream, spanning, and intermittency. No history of any episode of the acute retention of the urine, no history of the catheterization, graviuria, and genitourinary instrumentation, no history of any trauma, no history of having take aspirin and clopidogrel, no history of the loss of appetite, weight loss, coughing, restlessness, back pain, jaundice, no history of the decreased urine output and lower limb edema. Under the past history, no history of the similar complaints in the past. There was history of the diabetes mellitus since 4 years that was controlled, and no history of the hypertension, tuberculosis, and coronary artery disease, and no history of any drug allergy, no history of any medication other than glimepiride and metformin for the diabetes, and no history of any surgery in the past. Now, personal history. Patient was a smoker for 40 years, and patient was consumed 20 ml per day. so 10 years, and he was a farmer by occupation. He has normal bowel habit, normal sleep cycle, and no significant history. This is all about history.
So, Dr. Sanjay, just briefly summarize the history, and then we would invite our invitees, Dr. Aditya Pradhan and Dr. Bansal, to add something if they want in the history. And I would request Dr. Aditya and Dr. Bansal to ask our third-year resident as we actually examine in the examination, right?
Good evening, sir. Am I audible?
Yes, you are audible. Just briefly summarize exactly what is the history.
So 64-year-old farmer male patient present with complaint of 3-month history of gross total painless hematuria with patches of clots with increased frequency. Patient is a known case of diabetes from last 4 years, and diabetes is well controlled, and patient is chronic smoker.
Right. So, Dr. Aditya, you can go ahead asking question to Dr. Sanjay. First of all, Dr. Sanjay, would you like to know anything in the history besides what he has already said?
Sir, in history about hematuria, I want to ask whether he has taken any treatment for hematuria or consultant anywhere.
No, sir. Patient had a symptomatic treatment in a local hospital near his place. So, not evaluated further.
Not evaluated further. And patient also having increased frequency of micturition, which is daytime is 8 to 10 and nighttime is 2 to 3. I want to also ask about the voided volume in per void, whether it is less or.
According to patient, the voided volume was 200 to 300 ml at a time.
200 to 300 volume.
Yes, sir.
Any history of constipation?
Yes, sir. No history of constipation.
No history of constipation. Any history of recent urological intervention?
No, sir.
Any history of any past history of chronic UTI or chronic indwelling catheterization?
No, sir. No history of any chronic UTI or any catheterization recently.
And in drug history, I want to ask about any patient whether he's taking any either blood thinner or anticoagulant.
No, sir. Patient has no, sir. There was no history of any blood thinner.
And any other previous history of chronic analgesic intake?
No, sir. No history of any analgesic intake chronically.
Sir, I think it's complete.
Sir, you are muted.
Ashish, the support team. Ashish, please unmute Dr. Aditya Pradhan, please.
यस सर, मैं उनको रिक्वेस्ट भेज रहा हूँ, उनको एक्सेप्ट करना है.
हाँ, आप ना डॉक्टर आदित्य प्रधान, डॉक्टर बंसल, डॉक्टर गोविंद शर्मा और इन दोनों को आप अनम्यूट करके ही रखिए, राइट?
यस सर, वो अनम्यूट ही रहेंगे क्योंकि वो को-होस्ट ही है, वो अपने आप को अनम्यूट कर सकते हैं सर.
ठीक है.
Okay, can you hear me now?
Yes, Dr. Aditya. Yes.
Okay, great. So, can I? Who is the person I'm addressing in the third year batch?
Dr. Sanjay Saini.
Sanjay, can I ask you a simple question? 63-year-old, I think there was a history of smoking, presenting with hematuria and cloturia of some duration. This is your presentation, along with some irritative voiding, correct? Some irritative voiding symptoms. What do you think are the 2 most or 3 most likely scenarios in this patient? What are you dealing with most likely?
So sorry, sir. In last no.
See, Sanjay, he's asking what is the differential diagnosis of such a presentation?
Okay, sir. Sir, my first differential diagnosis is which came in my mind is carcinoma bladder. Second is sir renal cell carcinoma, and third one is as patient is old age and history of fluids is there. So I want to keep my third diagnosis as benign prostatic enlargement.
Okay. So you would place your first diagnosis as carcinoma bladder, right?
Yes, sir.
Okay. Now to that end, what further information do you seek in this patient?
Sir, in further information apart from history, I want to examine patient and further investigate.
Okay. So do you want to go ahead? The presenter can go ahead.
So Dr. Aditya, is he missing anything in the history, or would you like to ask him something about the history? Otherwise, we'll go ahead.
I think it's all right from the information available that he has been a smoker of some duration. That's what I could hear while I was switching. Is there? Yeah. So there you have. He has got a 10-pack history, or 10-pack year history, which is a long history, and he's got a farmer predisposition. So you have got 2 risk factors. Do you agree, Sanjay, towards
Yes,
your
sir.
diagnosis? Do you agree?
Yes. Yes, sir. Sir,
Okay.
first thing
So
is
if-
patient is chronic smoker and
Yeah.
by occupation he is farmer. So there may be a history of exposure from some chemical carcinogens.
Right. Are you aware of what exactly in smoking produces a risk factor for any of those cancers you mentioned?
Sir,
Are
in
we-
his
Are we aware of some factors in the cigarette smoke?
sir, there is production of aromatic amines and
Aromatic nitrosamines, right? That is correct. That is
Aromatic
actually the
nitrosamines.
main factor there. And as a farmer, he may have been exposed to some degree of exposure to pesticides. Maybe
pesticide chemicals.
he may not be able to quantify that, right?
So
Okay.
we have Dr. Bansal with us. Dr. Bansal, if you are with us, if you want to have any comment on the history, please go ahead.
Yeah, I am here. I don't know. I can't see whether I am visible there.
Put your video on, please.
Yes, it is. Okay, we will do that later on without wasting time.
Yes,
you see,
yes,
even
go ahead.
history is very important in hematuria. When we ask about hematuria, whether it was total hematuria, initial hematuria, terminal hematuria, or the clots were like worm-like, that suggests that it may be coming from the upper tract, whether it was associated with pain or followed by pain. That also gives us some idea about the origin of the hematuria in the body.
Right, right.
So even that is important because
Right.
half the work can be done there only.
Right. So this patient has a total gross painless hematuria with passage of amorphous clots, as the history says.
Yeah.
So probably this goes more in favor of, yes, the first differential diagnosis, as he said, CA bladder. And I think we should ask him to go ahead with the physical examination. So yes, physical examination.
Yes, sir. In a physical examination, the ECOG score 1, and patient was conscious, oriented, and cooperative at the time of the physical examination. Patient pulse was 80 beat per minute, BP 130 by 80 mm of mercury. Patient was afebrile, respiratory rate 14 per minute, and there was no evidence of pallor, icterus, clubbing, cyanosis, pedal edema, and any lymphadenopathy. CNS, CBS, and respiratory system no significant abnormality. In a local examination per abdomen, the abdomen was scaphoid, no dilated superficial veins, no suprapubic fullness, palpation soft, non-tender, bilateral, renal angle non-tender, and Huntington's side was normal. In our external genitalia meatus, there was no meatal stenosis, is normal, and rest examination was normal. And digital rectal examination, anal tone was normal, and prostate was grade 1, and smooth, firm, non-tender, non-nodular, overlying mucosa mobile, and no blood staining on examining finger.
So just stop here. So Dr. Aditya, yes, please go ahead.
Okay, Sanjay, are you any wiser from this quick thing? His general parameters have been reported normal, and his clinical examination did not find anything, right? Now, are you any wiser from where you started off at your history stage?
Yes, sir. As in history, there is no history on examination. There is no suprapubic fullness, which suggests patient is in note retention and.
Yeah, hello.
And
yeah,
prostate is also grade 1 smooth non-tender, and overlying mucosa is normal, which suggests which rules out diagnosis of carcinoma prostate.
Yeah, fair enough. I mean, even if there is a focus in the prostate, it's likely to be very small and not likely to produce this presentation. So effectively, your diagnosis 3 of CA prostate being there or not being there, I think you're right. You're heading more towards diagnosis 1 and diagnosis 2, right? Now, what further would you like to do in this patient? Anything further you would like to do examination, or shall we proceed straight to the labs, radiology, and next?
So Sanjay, do you want anything in the examination that he might have missed?
Sir, in general examination, in external genital examination, in scrotal examination, I want to ask about any presence of non-reducing varicocele.
No, he has said already is normal.
That is
examination is normal.
I think you can proceed because by and large there is nothing much more to add in this.
Right. Yes. So yes. So Dr. Bansal, also you please
yes.
come in anytime you want, right? Just
no. Yes.
Okay. So Sanjay, so which investigation you would like to ask for?
Sir, I would like to ask first set of investigation which helps to clean chain diagnosis, in which I want to ask urine routine microscopy, urine culture, ultrasound KOB, renal function test, and urine cytology. And patient is history of gross hematuria. So I want to ask also know about hemoglobin of patient and renal function test also.
Okay, go ahead, Sahib.
In investigation, the hemoglobin was 11 gram per deciliter, total leukocyte count 6,800 per cubic mm, and platelet 2 lakh per cubic mm, and BTCT and BTNA was normal, RPLFP was normal, and serum PSA 2.1 nanogram per ml, and HbA1c is 6.2%. In urine analysis, the pus cells was 4 to 6 per high power field, and RBC 50 and 50 to 60 per high power field, and cast nail, crystals nail, nitrates was negative, and leukocyte esterase was negative. Urine for malignant cytology was negative.
So can I stop you here? Let me just stop you here for one.
Yes, Dr. Aditya. Yes, please.
So Sanjay, there's somebody else who's talking actually.
Yeah, Ashish, please mute others.
Yes, sir.
So Sanjay, there is a patient who's your patient had gross hematuria. Okay. Now, what do you think is going to be the sensitivity of doing a urine cyto when there's been gross hematuria? Or would you like to tell your pathologist this aspect before you send the sample and apprise him?
But sir, as hematuria is intermittent,
okay, let me just stop you here. I'll just clear this straight away. When you have gross hematuria and you're asking for a cytology report, the lab has to be very careful in this patient's slide. It requires a good cytospin to remove the RBC and then look in that sediment for malignant cells. So it's incumbent on you when you're sending the sample off to the lab to let them know this patient has gross hematuria and the cytospin should be done carefully and evaluated by an experienced pathologist. Otherwise, you're likely to land up with negative. All right. So I just wanted to put up this point here. Okay, please go ahead.
So why, can I ask a question? Just Sanjay, why did you ask for urine culture in this patient? There was no, in your differential diagnosis, you never thought of infection being a cause of hematuria here.
Because our patient having history of frequency, so there may be some associated UTI. That's why, sir, I ask about culture, sir.
So in this case, probably urine culture was not warranted. If the urine routine microscopic showed something, suggested something, you might have, but otherwise the history also doesn't suggest UTI anyway.
Sir, can I make a comment, sir? Just
yes,
sorry,
yes,
sir.
Nachiket, please go ahead.
Sir, the patient was diabetic, so I think that the patient was diabetic in the history.
Okay.
So just for the residents now in 2017, always they should ask in a diabetic patient, especially if they're thinking CA bladder, if the patient took pliagitazone. This is because now that has been strongly associated with the development of CA bladder. This anti-diabetic, which is used for type 2 diabetes. So if the patient is diabetic, then they should include it in its history. This is because there has been a warning in 2017 of pylogitazone causing CA bladder. So just for the residents, it's important to take this specific history these days. They might be asked inside the exam also.
Okay, very, very good point. Sanjay, were you aware of this thing? That is anti-diabetic causing carcinoma of bladder?
Yes, sir. Pioglitazone causes bladder cancer.
Yes, so you should know this, and you should actually ask the drugs that he is being taken for diabetes, right? Okay, so go ahead. So he is not taking that drug, right?
Yes, sir. He is taking glimepiride and
right, fine.
This slide showing the X-ray chest PA view. Investigation is ultrasonography KOB. Is suggested right kidney normal in size, shape, and echo texture with CMD. The left kidney is normal in size and shape and slightly increased echogenicity with CMD maintained. And in a urinary bladder, a irregular growth of size 20 into 9 mm, which is present at the right posterior lateral wall, and prostate size 30 cc, P void volume 300 ml, and post void volume 20 cc.
So Sanjay, you've seen this growth now. They have shown you this. What do you feel looking at this ultrasound picture?
So there is around 2 centimeter growth is present in right lateral wall of bladder, and kidneys are also almost normal, sir.
Can this be a blood clot?
No, sir.
Why not?
This may be because our blood clot in real-time ultrasonography, when we change position of patient, blood clot will move, sir.
I'm showing you something on your screen. What is this? This. Can you see my arrow?
No, you won't. He won't be able to see your arrow.
Sorry. So
unless you have your screen.
There is blood flow at the base, which is seen on that screen on the right image. On the left image, there's a green arrow showing the margin of the bladder. But the right screen is probably showing some amount of Doppler flow there. I presume that they have done that. But either ways, when a Doppler ultrasound has been done, they have to document presence or absence of vascularity. Otherwise, it's very difficult to say there's a clot sitting there, or is it tumor. You mentioned the second test, which is postural variation, the position of that, right? So these two things are important. And the third thing you pointed out was upper tract dilation, right? So these are the three parameters on ultrasound which are important.
Yeah, so good points. Sahib Singh, just show with your arrow on this green line, which is on the right-hand side. Yes, there's just bladder tumor, right-hand side, yeah, this green line. So this green line, which may be a part of the Doppler study, which might be showing the vascularity. And there on the right side, there is some red spots also. So they might have done a Doppler, as Dr. Aditya said. So it's a way we can differentiate between blood clot and tumor, besides the movement, as you said. So go ahead. So what would you like to do now? Would you go ahead with a CT or you would stop here?
As the tumor is less than 3 centimeter in size and solitary tumor, and there is no associated upper tract changes, upper tract hydronephrosis. So we can directly go for cystoscopy.
Especially there is one more investigation that you did which was that investigation which goes again in favor of kind of non-muscle invasive nature of the tumor is the urine cytology that was done?
Urine cytology
was negative, right. So again, there might be some controversy again amongst the clinicians whether you should stop here and go ahead with a cystoscopy and a TURBT, or you should first do a CT scan abdomen in such a patient. So I would request Dr. Aditya to give his comment on this. Yes.
So what do the first, what is my take and what do the guidelines tell you? I think we should understand clearly what we as clinicians do. So what am I looking at in a CT? I'm looking for the loco-regional staging. That is what I'm looking at. Now, if my ultrasound shows me a small size, like in this patient, it's small, it's about 2 centimeters, and it's likely to be superficial and papillary. So in this kind of a situation, probably a CT is not warranted. I will get no additional information from that. However, the guidelines are silent on a size cutoff. So if you go by the guidelines, even the European and the NCCN do recommend a CT Euro prior to any intervention. Okay. So guidelines wise, a CT or even an MRI has been mentioned. But as clinicians, if we have clear evidence of low grade papillary growth, we can safely avoid a CT prior to TURBT. So that is my take.
Right, exactly. I also feel, particularly if the urine cytology is negative and you think the tumor is smaller than less than 3 centimeter papillary tumor, probably we can avoid doing a CT scan in every patient, which can save a lot for the patients. So I think, yes. So Sanjay, so you would do a CT or not in this patient?
I want to do CT, sir.
Okay. So let's go ahead with CT scan.
CCTKV with the urography report. The report suggested of heterogeneously enhancing soft tissue density mass lesion seen arising from the posterior lateral UV wall of size 20 into 16 into 16 mm with no exophytic component. Fat blend with the prostate and seminal vesicles are preserved. No perivesical lymphadenopathy. No hydroureteronephrosis seen. No radiodense calculus in either kidney or in either kidney. And normal contrast excretion in both sides. And both kidney are normal in anatomical position and structure. And prostate is mildly large size, consisting of mild prostatitis. This is a small video clip at the bladder level, Excel view.
Sir, I want to ask one question, sir.
Nachi, yes, go ahead.
Dr. Sanjay, see the point that was being made by Dr. Aditya Pradhan, sir, and now what additional information have you got inside this patient by getting a CT done? If there would have been some changes inside the adjacent wall of the bladder, if there would have been thickening of the bladder wall, or if there would have been, you know, some suggestion on the ultrasound that there might be some perivesical stranding, then I think that you would have been right in doing a CT scan. But it is just exactly complementing the ultrasound report. No additional information was gained by your CT.
Sanjay, is the CT complete, or would you like to see something else on the CT also?
Sir, apart from tumor, I want to also about extravesical extension status of lymph node upper tract changes.
Okay. Well, lymph nodes, he has already said there are no lymph nodes. Okay. So upper tracts are important. Why?
Because
One is you said about the dilatation. Anything else?
Dilatation of upper tract, sir, and also can look about metastasis in liver, sir.
No. In the kidney, in the upper tract, do you want to see anything else?
Sir, in excrete images, we can also search for upper tract urothelial carcinoma, which will appear as a filling defect in urine.
Exactly. That is why you actually one of the reason why you do a IVP or a CT urogram in such patients, because there may be a synchronous lesion in the upper tract also. What is the incidence of a synchronous lesion in the upper tract with a bladder tumor?
Sir, in synchronous upper tract urothelial carcinoma is found in around 1.8% cases.
Right. So it is quite low, right?
Quite.
So bladder tumor with an upper tract lesion synchronous, it is there, but it is a low lesion. The incidence is low.
But if tumor is located at the
Dr.
region
Adit,
of
any comment?
So I would actually tend to a little bit differ here. See, what I feel is that when we are saying synchronous lesion, you don't know what came first. If this patient had presented to me a couple of months back, and then I knew there was something sitting in the bladder and nothing in the kidney, then I was safe to go with the 2% or 1.8% which you mentioned. But he has presented de novo to me. So at this point of time, I don't know what came first, even if there was a lesion sitting there. So my ultrasound has shown me nothing grossly. So if I have to look at the upper tract, my main aim in looking at the upper tract would be basically to see the functional aspect of it. Because my next thoughts are in the lines of, when I'm going to treat my head with chemo, is he a cisplatin eligible, illegible person? Those are the thoughts that come to my mind first, rather than this second lesion which we are talking about, right?
So you think there is no point in trying to see upper tract urothelial lesion in a bladder tumor, urothelial tumor?
The setting which we are talking about is a patient who is presented to us de novo. If I had known his status earlier to be free of upper tract, and now I find something on the ultrasound, yeah, I agree with you, sir, then we should be going for it. But this fellow is presented de novo to you. His upper tracts on ultrasound are absolutely normal. So my chances that I'm going to pick up something there with a cytonegative status is very low.
Right. So you think because ultrasound might miss, urothelial lesions definitely can be missed by ultrasound,
yes.
Upper tract. So and the urine cytology also sometimes may not be always positive with upper tract urothelial tumor. Yeah. Anyway.
See, can I come in?
Yes, please go ahead, Dr. Bansal.
See, most of the tumors of the bladder tumor or the associated one are the transitional cell carcinoma, and they are multilocationals. So it is better at one time to get a baseline that no lesion was missed, because I have seen many sonographies where even the tumors in the bladder have been missed. So I would prefer to have a CT where we already know that there is a tumor in the bladder, but since it may be multilocational also, CT will be desirable.
Okay, CT urogram, either CT urogram or intravenous
urogram. Yes.
Yeah, fine. So, right. So now we have a bladder tumor. There is no lesion in the upper tract, and the upper tract is not dilated also. Go ahead, Sanjay. What will you do in this case? Yes.
Sir, after doing routine investigation for PEC workup, I want to proceed with for treatment of patients.
No, what treatment? That's what we are asking. What? Still, you don't know. Still, you do not know this is whether it is a carcinoma bladder or not.
Yes, sir. Sir, first of all, in the treatment, I will counsel the patient for stop smoking, and after that, patient.
Sanjay, here you are slightly mistaken. Don't say that you are going for treatment, right? Still, you do not know exactly the pathology, right? Yes, 99% chances it would be a transitional cell carcinoma of the bladder, which is probably non-muscle invasive, but still, histopathology is confirmatory, right?
Okay,
so still you are investigating this case.
Okay, sir.
So what will you do next?
Sir, I will go for cystoscopy first and followed by biopsy, biopsy or complete TURBT if there is a lesion in blood.
So biopsy or complete TURBT?
Complete TURBT because sir,
why did you say biopsy in this patient? So this patient is a 2 centimeter small papillary tumor, which is quite visible. You have both the investigations available with you. So I don't think anybody would do just a small piece of tumor and would not remove the whole papillary tumor. Any comment, Aditya?
So Sanjay, what is the difference in outlook? Suppose I have a almost global disease, not this patient, but I have a large growth which is covering, say, the entire right way, lateral wall, it's on the dome, it's all over the place. This is one scenario. And then this scenario which you've got here, this is a patient who's presented with hematuria. There's a small growth in the right lateral wall. Is my outlook on TURBT in these two situations the same or is it different?
Sir, if lesion is small, then we will go for complete TURBT. And as in first scenario, if the almost bladder is filling from the almost whole of the bladder is filled from growth, then there are more possibility that it is already at advanced disease. And as by radiology, we can clinically we can also confirm that. And in that scenario, we will do biopsies.
So to put it simply, this patient who has got a massive growth is unlikely to be a person for non-invasive disease. He is likely to be a cystectomy candidate. So in that scenario, my aim of biopsy is simply getting the histopathology confirmed. My aim is not to completely resect the whole growth, which will probably be impossible to do safely in one sitting. Vis-a-vis this patient, he's presented with hematuria. The 2 centimeter growth is going to take me 15 minutes to do a TURBT and take a deep biopsy. So my outlook in this patient is complete removal of that, whether you do en bloc or you do it piecemeal, and to take a good deep muscle and send it to the lab, right? So here there should be no doubt. It is complete TURBT.
Okay. So should we go ahead with aimed? Acha, the Dr. Neeraj is saying that the aim should be a complete TURBT, even if it is a large bladder tumor. So the point here is sometimes what happens, the thing is important that you take both superficial and deep biopsy. Sometimes, even if it is a large tumor, you would not be able to take a deep biopsy unless you go till the base of the tumor and you resect the whole tumor. So in that case, also probably you need to do a full resection till you go to the base for taking the deep biopsy, which is important to know whether it is a muscle invasive tumor or not. So I think if it is even a large tumor, a single tumor, you can do a whole TURBT and take the deeper biopsy, which is easier to take after a complete resection. Yes, Aditya?
Yeah, so I'm not in disagreement. The aim should be clear. When I have a large growth, it is most likely this patient has got a muscle invasive disease. The chances that I will get a low grade or a lesion which is non-muscle invasive is low. That's the first point. The second point is the tumor resection time. If you're going to have a very large growth, your resection time is going to go up. If you can safely remove it without the patient becoming hemodynamically unstable, by all means, I will try and remove it. Okay, but if it is a very large growth, I'm not going to stretch my luck. I will do the minimum required. Patient is safe. I will come off.
But you will take a deep biopsy, right?
Obviously, yes. That is not compromised at all.
Right. So you will take a deep biopsy.
So rather than try to go through the entire growth, we would probably start at one point safe, away from the dome, away from the area where I'm going to get a jerk, take your superficial, take your deep, look at how much time you have spent, go ahead and resect as much as you can safely and come off.
All right. So if it is a broad-based, it can be done. If it is supposed as not a broad-based, it's a kind of narrow, it's a pedunculated kind of papillary lesion, then probably even if it is large, you need to resect the whole tumor to go to the base. So sometimes that difficulty can be there to reach to the base. So anyway, I think the more important thing is we need to take a deeper biopsy to know whether there is muscle invasion or not.
Absolutely.
Fine. So what will you do, Sanjay? Go ahead.
Cystoscopy and TURBT.
Okay. So again, because so which type of TURBT you will do?
Complete TURBT, sir.
Okay. So because nowadays we have another kind of TURBT, in particularly in such tumors, which is becoming a kind of standard therapy in papillary tumors. What is that?
En bloc resection of
En bloc. Yes. So this is probably a typical case for en bloc resection of the tumor. What are the advantages of en bloc resection?
Sir, advantage of en bloc resection is it causes minimal architectural distortion. So it helps pathologists to get exact histopathology of tumor. And second thing, in en bloc resection, there is a good amount of presence of deep muscle also is there. So muscle invasion can be also commented.
Okay, so in the one specimen only, probably you get the muscle also. In most of these, sometimes you have to take a deeper biopsy, even in that case also. But many cases you will get the muscle also in the en bloc resection. So that is a better histopathological diagnosis, and a resection which is en bloc because the principle of oncology is that you should not violate the tumor, as we do in other cases, like in renal tumor and all those cases. We would not like to violate the tumor by breaching its capsule or by cutting it, right? There may be a spillage and the chance of recurrence may be higher, though we do not have any studies at present. But definitely this is logically, it seems to be that if you can do an en bloc resection, definitely it would be oncologically also fulfilling the basic oncological principles of not violating the tumor. Any comment, Aditya?
So, sir, you have completed most of the points. I think one of the main things is the adequacy of the sample and the lack of the cautery artifacts in your specimen. Since you have gone below the epithelium and you have touched the detrusor and then shaved the tumor off the detrusor, you're likely to have a more complete resection. You have likely to have included the detrusor and you have not cauterized the surface. So you're unlikely to create cautery artifacts on the sample presented to the pathologist. So in all three counts, the adequacy, the depth, and the lack of artifacts, en bloc scores over conventional piecemeal TURBT. The problem is the limitations in terms of instruments that you have, because to do a proper en bloc, you should have a flat blade if you're doing the cautery, or you need to have a laser. Most often we do not have them in our armamentarium. If you have them, that's very good. You can try it.
Right. So usually what we do is we are doing a lot of en bloc resections nowadays, particularly for these tumors. You can do it with Collins knife also. So Collins knife, I do it personally with Collins knife, which is available in the OT everywhere. So that is, and the laser is definitely most of the times available. Yeah. So laser and with Collins knife, because these two are the instruments which probably you can do all types of en bloc resections. So which are available in any way in the OT. So, okay. So let's go ahead.
Ask something to Sanjay, sir?
Yes, Neeraj, go ahead.
Yeah, Sanjay. So you said you will do a complete TURBT. Any role of random biopsies in this particular patient? And if so, what is the indication?
So Sanjay, would you do a random biopsy in this patient or not first?
Sir, if there is any during cystoscopy, if there is any mucosal changes, then I will do
Right.
biopsies.
So what are you suspecting
And,
if there are mucosal changes?
Sir,
What are those mucosal changes called?
Sir, red velvety mucosa.
What are they called, Sanjay? Tell the terminology. It's carcinoma in situ,
Carcinoma in
CIS.
situ.
Yeah.
Right. So you are suspecting carcinoma in situ
Carcinoma
probably.
in situ.
So you need to take biopsy. So suppose the urine cytology was positive.
Positive.
Would you take a random biopsy in this patient?
Sir, we can go for random biopsy according to scopy finding. If the tumor looks like low grade.
Sanjay, just listen to the examiner what he's asking you, right? You have the cystoscopy finding with you. I am asking only if the urine cytology was positive, would you take random biopsy or not? Even if
No,
the
sir.
cystoscopy shows normal bladder mucosa. No?
No, not in this
So why are
patient.
you saying no, Sanjay? The setting is a positive cytology and negative bladder cystoscopy. Now, this is a classic scenario where you need to think, what else am I missing? How can you explain the cytopositive? Obviously, there's something missing, right? Where would you look for that something missing?
Sir, I was thinking about this case, sir. That's why I refused.
No, this case only. This case only, dear. If the cytology was positive,
I
right?
will not take, sir.
So that, yes, you will take. If the cytology was positive, the CIS can be missed on cystoscopy, right? So cytology would not be positive in such a superficial papillary small bladder tumor. Almost very unlikely. So in that is one of the indications for taking random biopsy and a posterior urethral biopsy.
Absolutely.
If the cytology is positive.
Sanjay, what is the preferred means of taking a random biopsy?
Preferred means and where would you take it?
Sir, it will be taken from representative area of bladder like dome, trigone, right lateral wall, left lateral wall, anterior wall, posterior wall, near from ureteric orifice, from bladder neck, and from prostatic
left no space, all bladder. Anyway, so posterior urethra is important, and you have to take a random bladder biopsy, usually on the opposite wall, plus any, suppose if you get some hyperemic area, that also area you will should be taking. So yes, 2 to 4 random biopsies and 1 posterior urethral biopsy, I think would suffice.
What is the preferred means of taking it? Do you take it with the electrocautery or some other means?
So what is the other way to take a biopsy, Sanjay, besides the cutting with the cautery?
Cold cup biopsy, sir.
Cold cup biopsies.
Fine. So that may be taken, but I think even if you can take a pure biopsy also. Anyway, so suppose there is a urine cytology positive and you are missing. Is there any investigation or any means by which you can increase your chance of looking at the CIS or any other lesion that you might be missing on cystoscopy? What are the other ways of looking in the bladder besides the conventional cystoscopy?
There are, sir, also few modalities like fluorescence cystoscopy, narrowbanding imaging, by which we can increase our diagnostic.
So that is important. So I should say that if you have a facility for narrowband imaging or a blue light cystoscopy, you may actually see some of these lesions which were missed on the conventional cystoscopy. All right. Aditya, any comments?
Yeah, in fact, I want to go one step before this. We have talked about NBI and saying, by and large, the enhanced imaging with photodynamic utility has almost been given up. We are more or less now confined to NBI.
Yeah.
In those centers where we have those instruments, we can use them. That's the one thing. The second thing I wanted to ask the candidate was his choice of anesthesia. Here is a growth which is on the lateral wall. What kind of anesthesia would you use when you're doing this procedure? Are you happy with a spinal, or are you going to ask for a GA, and if so, why?
Sir, I want general anesthesia plus complete muscle paralysis to resect lateral wall bladder tumor
Okay.
in way to minimize the chances of operator jerk.
Right. That's what I wanted. Actually, a very clear answer that we would prefer to use a GA if possible, and if it is not possible, then you're going to use spinal with some ancillary maneuvers, right?
So what are those ancillary maneuvers, Sanjay?
Sir, spinal with added operator block.
So obturator block. So do you know how to put an obturator block? Have you
Sir,
seen it?
No, sir.
You haven't seen it?
Not yet, sir.
We have been doing in many of these patients. Okay, you might have missed them. So do you know any idea how to do it?
Sir, by doing parectal examination, we try to feel.
I don't think there's anything with the parectal examination. What is the site where you would inject? How would you go ahead? Is there any other way by which we can actually block the obturator nerve? Where is the obturator nerve?
Sir, after palpating pubic tubercle, we trace the pubic rami and direct the needle toward anterior superior iliac spine and at that site.
Okay. So I will not go into the details, but you should know how the obturator block is given, right? Okay. So suppose in the GA, under GA anesthesia also you feel that the patient is having jerk. So what will you do? So reduce the jerk, even if the patient is under general anesthesia.
Sir, resection should be done with partial filled bladder, not in fully distended bladder.
Okay.
And using bipolar energy sources also reduces the chances of.
Okay, but that is debatable. Anything else? Anything else? See, there are two things that one is you can ask the nurse, and the other thing you can ask your anesthetist. You have been doing it so often, Sanjay. So what will you ask the nurse to do? Reduce the?
Hold the limb, sir.
Oh no, not hold the limb. How will that avoid? Reduce the cautery setting, dear.
Reduce the
cautery setting can be
doing resection in
cautery setting
lower current, sir.
Yes, with the lower current. And what to the anesthetist?
Anesthetist to give relaxant at the same time.
Muscle relaxant. So maybe it has waned off, right? The muscle relaxant might have waned off. It may not have been that deep. So you have to ask the anesthetist, right? Okay. So we have done TURBT in this patient. And so what will you do next? So TURBT has been done. Anything else you want to add to it?
Sir, I want to send a specimen in two separate containers in which in deep muscle biopsy should be sent in.
Okay, so you have sent this superficial and a deep biopsy from the base. Anything else?
Sir, after that, if patient urine is clear and there is no hematuria and we are not thinking about perforation of bladder, then we will go for single instillation of intravesical chemo.
Okay. So which chemo?
Mitomycin C.
Dose?
Dose are 40 mg in 40 ml, 40 or 50 ml saline.
Of?
For 1 hour.
40 ml of what?
Normal saline.
Okay, right. So you will keep it for 1 hour and then. So usually you have to give a single dose of intravesical mitomycin in most of these patients, unless if they are not very obviously non-invasive and solid tumors, right? So, Sahib Singh, was mitomycin given in this case? Sahib? Okay, so mitomycin was given. Sahib Singh, share your presentation. Sahib? Okay, so there was a mitomycin given in this patient, and then what would you do next? When would you remove the catheter and what would you do next?
Sir, catheter, I will like to, sir, ask about biopsy report.
So biopsy, how
Can
long?
I come in?
Yes, yes, Dr. Bansal, please go ahead. Dr. Bansal, please. Okay, so the histopathology usually takes maybe 4 or 5 days, and in our setting, in our college, it takes even 10 days. So you would not wait for the biopsy to remove the catheter, would you?
So we can remove catheter on 3rd or 4th day, depending upon the color of the urine and.
Okay, so in this particular case, probably you don't need to wait even that longer, right? Maybe on the 2nd day, you can remove the catheter. Yes, Dr. Aditya, any comment?
No, I absolutely agree with you. There is no need for keeping the catheter very long. Maybe on the next day, if his urine is clear, he has passed stool, you can just take the catheter out.
Right, exactly.
Give him another day and get the catheter out of the 2nd day. That's it.
Now,
I want to just quiz you a little more about your single dose installation. You have said mito, you have given a dwell time of 1 hour. Suppose you had a little bit of hematuria, would you still give the mito? If yes, what would you do? Mild hematuria is there, or if it is a nice red urine is coming out. In these 2 instances, mild hematuria and then lot of hematuria is there. That means your hemostasis is not proper there. Would you give mito in that case also?
No, sir.
What is the risk? Why are you not giving it?
Because, sir, there will be systemic absorption and toxicity for.
You're giving a very high dose, is practically going intravascular. You're giving 40 mg. You can be prepared for a lot of myelosuppression in these patients, and it is not advisable. Absolutely, I completely agree with you. Now, my second question to you is regarding the alternatives. You have said mito is there. Suppose your pharmacy says we are run out of mito. Is there any other alternative I can use?
Sorry, epirubicin?
Epirubicin. Epirubicin is not easily available. In fact, I don't see it ever. But more commonly is gemcitabine. It is very commonly used. In fact, it is cheaper than mito. So today, in fact, if you see the literature, there is more literature on gemcis being used as, not gemcis, plain gemcitabine as a single dose rather than mitomycin. It's cheaper and it's equally efficacious. There's no head-to-head comparison, however. Okay, so it is an equally acceptable single dose. Please go ahead.
Right. As rightly said, gemcitabine can be given, and usually we give it when the BCG is unresponsive. Gemcitabine and docetaxel combination also sometimes. So yes, so mitomycin single dose or gemcitabine single dose. So this was given in this patient. Mitomycin was given. Go ahead, Sahib.
So after this procedure, we discharged the patient after the 2 days. And with advice of come in a urology OPD with a biopsy report. The biopsy report is of high-grade urothelial carcinoma, in which lamina propria invaded by the tumor and muscle propria not invaded. So pathological staging is T1.
So Sanjay, would
you just analyze this report? You had a cyto which was negative. You had a papillary growth. Your visual impression is it was a low-grade papillary. Now this is the histology. What do you make of this histology?
Sanjay, what do you think it is?
So there are many markers here which we need to see. First is, was your biopsy adequate? So it seems to be adequate because they have found muscle. And they've said the muscle is not invaded. So that is your first point. The second point is it is high grade. So it's a TA high grade disease, right? Now, it also mentions lamina propria invaded. Okay.
So it is T1 then.
So it's a T1, exactly. So it's a T1 with propria invasion. So it's probably 1B disease. Now,
yes.
Now what are your what is your thought process on this? What do I need to do from this report?
So Sanjay, can you risk stratify this patient? How do you do a risk stratification in a case of CA bladder? Which risk it is now?
It comes into category of high risk, sir.
It comes into what category?
Category of high risk.
into high risk. But before you say high risk or low risk, you have now this report, right? His muscle is not invaded, but it is high grade. Okay. Would you consider doing something more, or you will start your treatment right off? Now, okay, I've got this, I've put him down, I've labeled him as high grade. Should I start with my therapy right away, or I should do something else?
Sir, we should restage patient as there are in PT1 disease with high grade tumor, there are more chances of restaging in first biopsy. So I want to go for re-TURBT.
So I entirely agree with you. Here, though there is a muscle which has been provided, you have provided muscle in that sample. However, there is a discordance between your visual impression and the final grade. So first I will go and talk to the pathologist. I'd like to see the slides with him and understand what he has said by muscle and whether it is actually seen or is looking at the lamina propria only. That is the first thing I'll check. Now, if I am very clear that I have done a proper TURBT, I have given him muscle, then probably I will not do it. But if I have a doubt, and it is always benefit of doubt to the patient, then re-TURBT is what the guidelines tell us. We should do a re-TURBT in this situation. Dr. Shivam, your thoughts?
Yes, exactly. So restaging TURBT should be done. Patients who have a T1 lesion or with a high-grade lesion when you are doing a resection and the biopsy comes as high-grade or T1 lesion. So I think we did a restage TURBT. Sahib Singh, go ahead.
So patient was planned for the re-TURBT after the 4 week of the initial section. So intra finding was meatus and urethra normal and bilateral urethra is nice, and previously resected area seen over the right posterior lateral wall. At that site, a biopsy was taken and no residual growth.
Right. So what was the biopsy report? Go ahead.
The biopsy report was high-grade urothelial carcinoma and laminar propria invaded by the tumor and muscle propria present in the biopsy and not invaded. And the pathological staging was then T1.
So exactly the same biopsy report.
Now, what do you say? What group do we place this patient?
Sir, we have double confirmed about muscle propria and invasion. So we will assume this patient PT1 high grade, and before going for this stratification, I want to also look for whether presence or absence of carcinoma in situ in biopsy report.
No, they have not mentioned it anywhere here. The assumption is that they did not find, but you have not done any random biopsy either. So we assume that, okay, he had a 1B disease. There is no concomitant carcinoma in situ. And this is conventional TCC. It is not a variant histology.
Okay, sir.
This much we have got from whatever the lab has told us, right? The only point which is a little bit against it is that the size was small and it had a papillary appearance. That's all. But otherwise, histopathologically, it is a 1B disease, high grade, so it goes into high risk patient.
High risk group.
Now what do we do? You have given him a single dose mito after your resection.
So what will you do next? Yes.
According to risk group classification, it comes in group of high risk. So I will plan for intravesical BCG.
How about considering mito? Can you give mito in this group, or should you give only BCG? Is there any data telling you what, where, or what do the guidelines tell you? Let me just ask you that.
Sir, in a high risk patient, intravesical BCG will be more better in terms of recurrence and progression as compared to intravesical chemotherapy.
Absolutely. It's only in the intermediate risk that we have that option of considering mito. In a high risk group, it is always better to go with BCG. You want a better response rate and you want definitely a lesser progression rate. So I agree with you. You should consider BCG.
One thing that I would like to add in the biopsy report, which Sanjay should have asked the pathologist. One is, as Dr. Aditya said, it should be, you should ask whether it is a deep invasion of the lamina propria or a superficial invasion, right? In this case, as it is high grade, it is probably as a deeper invasion, as he said, 1B probably, T1B, right? And secondly, you should also ask about lymphovascular invasion. So lymphovascular invasion again goes in more in favor of kind of high grade, and we may have to think in terms of doing a cystectomy or a more aggressive kind of treatment in such patients. So lymphovascular invasion, high grade, T1B, and all these go more in favor of aggressive treatment because the chance of recurrence and progress of the disease would be higher in such patients. Yes. Any comment, Aditya? Yes.
No, I agree with you.
Right. So I think, so what will you do next now? So you give intravesical BCG. When would you give intravesical BCG?
Sir, after 2 weeks completion of TURBT, we can give sir BCG.
So that is the induction therapy, right? So what dose?
Sir, 120 mg during induction.
Which BCG?
Live attenuated BCG, sir.
Yes, live attenuated. Which mycobacterium? Which strain? Which strain?
Mycobacterium bovis, live attenuated BCG.
Which strain you are giving usually?
Danish strain.
Danish. Yes. Which? So this comes by
Onco BCG.
Onco BCG. And the other one is Oncovac. That has which strain? Anyway, you should know all the various strains. Right? Moscow strain is probably the Oncovac is Moscow, right? So you should know all those strains.
Sanjay, regarding, sorry, sir. Yeah.
Yes,
just a small question to Sanjay regarding the dose of BCG. You said you will give 120 milligrams. So is it the standard dose to be given, or you can, give a smaller dose also? And what is your view on, a slightly reduced dose of BCG? Are people giving smaller doses also?
Yes, sir. People are also giving 80 mg dose. But sir, it depends upon, it varies patient to patient. Sir, if patient is tolerating 120 mg dose, then in induction course, we will give full dose, sir. And if there is some problem with patient, then we can reduce our dose to 80 mg.
So have you gone through the literature regarding the efficacy of lower doses of BCG comparing with the 120 milligrams, 60 milligrams with 120 milligrams, 80 milligrams with 120 milligrams? Have there been any comparison?
Sir, in literature, 80 mg and 120 mg, there is no significant difference in terms of efficacy. But if we reduce the dose to 1/3, like 40 mg, then it will definitely increase the chances of recurrence.
All right. So yes, there are studies, and particularly yesterday only in the webinar we discussed about the SGPGI people. They did a study on 80 milligram, and they have made it a protocol of giving 80 milligram only as intravesical BCG induction therapy. So, but still, not everybody follows this rule. And many people are giving 120 milligram only. Unless this 120 milligram is not tolerated, they will not reduce the dose. So that depends upon center to center, and I think that is agreeable probably. So Aditya, any take on the dose?
No, I agree with what you have said. In a patient who's being started, first is to lay out the protocol. Sanjay, you mentioned induction. No, it's not induction. It's induction and maintenance. So your plan is BCG induction, 6 doses, followed by maintenance. I think when you answer the question, the answer should be complete, not just induction. Otherwise, you give the impression that 6 doses and I'm done. No, that's not the treatment. The second is what was brought out was the doses. So the rationale was the CFUs per milligram of that powder. Unfortunately, even the Supfl Oncovac does not tell you how much CFU is there. And therefore, there was a dose reduction from 120 down to 40. Now, what has been found is that induction, you were right when you said you should try at 120. It does produce the best induction schedule. The problem is on the tolerance. So if you start at 120, the tolerance is good, you will continue at 120. However, if the tolerance is poor, you will bring it down to 80. Most of the attempts are to keep it at the highest tolerable level. Once you have that patient tolerating it, then as you go along, if the patient develops further intolerance, and this is the tendency usually, That induction goes well, and in the maintenance they start floundering, they start developing severe cystitis. Then you bring down the level to the lowest, which is tolerant to the patient. So those are the broad categories. And as I agree with you when you said that the higher the dose, the efficacy is better. But it does not mean that you need to stop it. In most cases, you can manage by a dose reduction.
Right. So yes, mild degree of BCG cystitis, you can reduce the dose. If there's a cystitis is very severe, then definitely you need to even stop the dose, and you might have to treat this BCG cystitis. So how do you treat, suppose this patient has a severe kind of cystitis with a lot of irritative urinary symptoms following BCG, what will you do?
Sir, in these cases, we can add non-steroidal anti-inflammatory drugs to patient, and
yes. So one is non-steroidal anti-inflammatory,
and another is bladder antispasmodic.
Antispasmodic.
Bladder antispasmodic.
Okay. So still the patient is having pain.
So then we can add antibiotics, sir.
Antibiotics. So do you think BCG cystitis will, with the conventional antibiotics that you give, patient will respond to these antibiotics?
Before that, sir, we will send patient's urine for culture.
Okay, so urine we have sent for culture, but the antibiotics usually do not work in BCG cystitis, the usual antibiotics. So what will you do? So there are the people, yesterday only, if you had listened to the webinar, the people, they give steroids also, and sometimes they respond to steroids. And then even if it is severe, then you have to give antitubercular, right? So because then it's a typical case of BCG cystitis where you have to add isoniazid and rifampicin sometimes also to reduce the symptoms. Any take, Aditya?
So I think what you said is absolutely right, sir. We try to grade how severe is the problem. Is he developing a very low grade fever? Is it a high 38.7 and above fever? Those need a little more attention. So you're right. You start with the simple medication like your NSAIDs, anticholinergics, and antispasmodics, and wait for 2-3 days to see his response. If the patient is developing high grade fever, you have a problem. You would then probably initiate bladder drainage, start him on antibiotics like you mentioned. And if in 48 hours you got no response, then you would have to label him as at least a grade 2 or a grade 3 cystitis. Now comes the question of 2 drugs versus 3 drug ATT, most often 2 drugs for a week or 2 weeks. And after that, you may add steroids rather than the other way around, at first steroids, then ATT. I tend to use ATT 2 drugs after 72 hours if fever and symptoms are not resolved. That's the way I look at it.
Right. In the meantime, I would ask Ashish, the technical support team, please unmute Dr. Govind Sharma, the moderator of the session. Please unmute Dr. Govind Sharma. Yes. So Sanjay, how would you follow up the patient? So after giving intravesical BCG, one is how would you give the maintenance dose?
Sir, maintenance dose is given according to SWOG trial, sir, in which 3 weekly doses are given at 3 months. After completion of induction course at 3 months, then 6 months, and then 6 monthly interval up to 3 years.
Okay, so the people give for 2 years or 3 years this maintenance dose. And there are multiple regimes. Yes, as you said, 3, 6, 12, 18, 24, and then 6 monthly. Or it could be people give a monthly dose also. So monthly single dose of BCG, as yesterday Dr. Anish Srivastava was saying, they give maintenance dose of monthly week, 1 dose of BCG. So there are multiple regimes, but what you said is probably more people do that in that way. Aditya, any take on that?
Yes, I have one important point which I'd like to ask Sanjay directly. Before you start on your maintenance schedule, which is at 3 months, are you going to do anything at that point of time? Or I've given my induction, patient is fine, and I go ahead and start the maintenance. Is there anything I need to do, or I'm fine? 3 months comes, Now I straight away start my induction schedule. Is there anything I need to do at this point?
At third month, sir, we will call patient for checoscopy.
So this is actually your most important check cystoscopy, the 3 months. Now you've answered that. Now tell me, why is it important? This 3 months, why is it so particularly important?
Because, sir, if we find any growth at on first checoscopy, which is done at third month, it by this we can prognosticate patient. It comes into worse prognosis.
So the first thing is that this is your first landmark to see whether your induction has worked or it has not worked. Suppose you have a growth and it appears in that area or in some other areas, it is low grade, it has one connotation. But if it is biopsied and it comes as a high grade, you have a problem at hand, right? What is that problem? Post-induction failure at third month, what would you call it? High grade post-induction failure.
Early BCG failure.
So this is actually what we would call as refractory. You have given him full induction, 6 doses, and now at your first check cystoscopy, you have a high grade recurrence. This is a problem. This is refractory. So which comes to an important question. Do you know what is the current concepts in labeling a disease as BCG unresponsive? What is your understanding?
Sir,
You're giving a patient BCG, at what point should I call it quits? No, it's not working. I have to think of something else.
Sir, should wait at least 6 months, sir.
Oh, okay. So this fellow has failed, and then I will wait a further 6 months before I take action. Is that what is our understanding?
No, sir. If there is a growth at first checoscopy, we will dissect the growth and look for biopsy. If it comes high grade, then we will start second induction course, sir. Repeat induction course.
Okay, you want to start a second induction in this patient if he's a high grade recurrence. Okay. And anything else you want to add? So in short, what is refractory? What is relapse? What are your ideas about that?
Sir, BCG refractory tumor are tumors which in which at first checoscopy at 3 months, if there is presence of T1 high grade tumor, and during the treatment of BCG, any biopsy report comes as high grade, whether co-current carcinoma in situ or isolated high grade recurrence.
Okay, so I'll try and put in some clarity if I can on this matter. The first is refractory. The second is relapse. And the third is the definition which recently was included, which is unresponsive. Now, is there really a difference between the two or the 3 parameters? The main things are what time have they appeared. So refractory indicates that your induction has failed, like in this particular patient, or if you have got only prior carcinoma in situ, you have given him 6 months, that means you have got induction, you have given him one more cycle, and still you have carcinoma in situ there. So this is refractory, it is not working. The second is relapse. Relapse is that your patient has responded to it. He was disease free for some time, and then after a year and beyond, he starts coming again with tumor, which is high grade. Anything which is less than high grade is not a BCG failure. Low grade is not a failure.
No grade.
Patient BCG intolerance is not a BCG failure. The last one is unresponsive, BCG failure definition. In that, 2-3 important points have come. First is adequacy of dose. That means that I have given him full amount of BCG, that is at least 5 out of the 6 induction and at least 2 of the 3 of the first maintenance. Okay, so adequate BCG was given. In spite of it, he develops a high grade recurrence. Okay, so adequacy of treatment, duration of when that thing came back, all these are important points marking BCG unresponsive disease. Okay. Now here is an example. I have just pushed you a question that at the 3rd month, that is right at front, he has a high grade recurrence at the 3rd month. You give him full induction and it has failed. So this patient is BCG refractory. What is our option? You have got to counsel the patient. He is at very high risk for progressing. Yes, you are right by saying that we can try another induction, but you also need to counsel the patients that the chances of him failing early and progressing are very high. So if the patient is young, if he is willing, he becomes a cystectomy candidate. If he's not willing, you will try a second induction, or you will switch to alternative therapies, which we'll talk about. Dr. Shivam, your thoughts?
Right, exactly. So in this case where there's BCG refractory, probably I would not give a second induction of BCG alone, because a high-grade tumor recurring so early, I think we should switch over to other kind of chemotherapy. If the patient is not willing for a cystectomy, we should go ahead with the alternative therapy. So I think, so Sanjay, if the BCG is unresponsive, which other alternate therapies you have intravesical?
Sir, in case of the BCG failure, patient is counseled and patient is told about that other treatment will be oncological inferior as compared to radical cystectomy. We have options of intravesical chemotherapy with.
So again, which intravesical chemotherapy?
Sir, we can give valrubicin, which is approved by FDA in BCG refractory cases.
So which is usually given, which is more common in nowadays, and usually gemcitabine or a combination of gemcitabine and docetaxel. That is what people are giving, which they think this is a more preferred. A combination would work better in some of these patients. Anything else besides chemotherapy? And anything you can add to the intravesical chemotherapy installation which will help in better absorption?
Sir, hyperthermia, microwave induced hyperthermia.
What is that typical instrument? There are so many people we today have, many of the centers have that instrument. What is that called? It's the HIVEC system, right? So HIVEC system, which helps in better absorption of these intravesical installation of chemotherapeutic drugs, right? Many centers now have this instrument, which will help to improve the absorption of these intravesical. Besides intravesical chemotherapy, any other drug? Do you have any other drug?
Sir,
have you heard of intravesical immunotherapy besides BCG? Any other immunotherapeutic drug?
The intravesical interferon.
No, not interferon. Not people are working on pembrolizumab. Right? Pembrolizumab, there are a lot of studies that is going on. So that is probably the next option before doing a cystectomy or the patient is not willing for cystectomy. Yes, Dr. Aditya, any take on this?
So Sanjay, let me just take you back a little. You said yes, cystectomy. Why do you recommend cystectomy? So I think you should very clearly tell the patient that you are a young person. If you do cystectomy in a high-risk candidate, you are actually almost curing the patient, because the 5-year survival is in excess of 95%. So here is a patient, a potentially life-threatening situation can emerge if he is not treated, goes to muscle invasive T2 and beyond. If you do a cystectomy at 5 years, you're assuring him of a greater than 95% survival, meaning you've cured the patient. So this is my first benchmark against which everything else has to be compared. Now, when we talk of what is the alternative, so the alternatives you think about are, like you mentioned, monotherapy, which is gemcitabine or many others, or couplets where you combine, first give him one dose gemcitabine, wash out the bladder, then push in the dosi. So you're giving doublets, or you can add even 3 drugs. So you can add 1, 2, 3 drugs in whichever combination we use. Okay. How much do we improve on what it was from BCG? Roughly about 8 to 10%. So you can reduce the recurrence rate roughly, if you use gem dosi, to about 45 to 47%. That's all that we achieve with this. Even then, about 60% patients will fail. The others were what you mentioned, which is heating the chemotherapeutic installations which go into the bladder by some devices or microwave, right? The next point was what you mentioned of immunotherapy. And in immunotherapy, pembro has been used mainly systemically. The intravesical pembro is not yet mainline. The systemic pembro has been proven to be beneficial. And the big advantage pembro trial has shown is that it reduces the progression. There is no progression. So even when they have done a cystectomy later, they were still found to be T1 disease. None had progressed to T2. So this has changed the natural history of the patient. Here was a patient who had failed BCG, and you gave him pembro, and the disease was arrested at that 1B stage. It did not go beyond. So it is likely that the response to pembro is going to be long-term and going to be beneficial to the patient. The obvious problem is the cost. The other things which have been added are viral therapy. Adenoviruses have been instilled, and they stimulate inside the bladder epithelium, inside the mucosa. They are injected and they produce locally interferon. So these are the few ways in which we are trying to do bladder preservation in patients who are failing BCG, right? But what is the bottom line? The bottom line in on guidelines is that any intravesical therapy in a BCG failure is inferior oncologically to a cystectomy. So I think that is what we should be having as our guideline today.
Right, Aditya. So point very well taken, Sanjay. Just remember this bladder tumor, which is a high grade or progressing to muscle invasive, is a fatal disease. So you need to convince this patient that cystectomy is your chance of living longer, right? So definitely you need to convince this patient for cystectomy if it is a high grade or unresponsive to BCG, again recurrence is occurring. Definitely you should convince this patient for cystectomy. Only if this is not convinced, then only we should take the other options. So this has to be very well understood. Right. So I think we have done, and almost we are running out of time also. So Dr. Govind,
Yes, sir.
I would request you to give vote of thanks, and then we will wind up the session.
So I would like to thank Dr. Aditya Pradhan and Dr. M.M. Bansal, sir, for your kind gesture and coming to our class and enlighten us with your kind knowledge. And in future, we also want your presence whenever we want, and it is a pleasure to meet you. Thank you, sir.
Thank you
sir.
very much. Honor to be with your team there. Thank you, Dr. Shivam.
Thank you, sir. Thank you. Thank you.
And,
thank you, Dr. Aditya. Thank you, Dr. Bansal.
Thank you, sir.
And all the viewers who might have joined us today. I'm seeing a lot of other people besides our department who have joined us. Thank you for joining us, and a very good evening and a good night ahead. Thank you very much.
Good night.
Actually, thank you.
Thank you, sir.
Very
thank
much
you.
for
Thank
making
you,
us part of this exercise. It's
Thank you.
a privilege. Thank you very much. Thank you.
Thank you, Dr. Bansal. Thank you.
Yeah.
Thank you, Dr.